Hi friends, welcome to today's live session. And today is again a very high topic in terms of examination. Basically, uh, it is a hematology topic where we'll be learning about chronic lymphocytic leukemia, also called as CLL. So let's start with our session. Before I start, make sure that you know like this video so that it gets stored as your history in your YouTube. If you are new to this channel, if you are attending one of my sessions for the first time, make sure you subscribe to our channel so that whenever I go live or any one of our faculty goes live, you'll get a notification. If you have any question or if you have any suggestion for future live classes, make sure you put in a comment. And obviously, if you like this session, love this session, share it with your friends. Let's start with our topic of interest today, that is CLL. Now, the first point which I want you to remember, and again, this has been asked as an MCQ, is what is the most common leukemia in adult? And the correct answer is CLL. So this straight away forms your first one-liner question, that what is the most common leukemia in adult? And the answer is CLL. Another question which is related, which you should know, is what is the most common leukemia in children? Okay, so again, it's a leukocytic or lymphocytic leukemia, but it is not the chronic, it is the acute lymphoblastic leukemia. Okay, so most common leukemia in adult, remember CLL, most common leukemia in adult, it is ALL. And because we are going to see the features in chronic lymphocytic leukemia, what happens? There is an infiltration of lymph node, spleen and lymph node, and that is the reason why it is also called as your small cell lymphoma. Again, very important point. So chronic lymphocytic leukemia is also called as small cell lymphoma because here, even though we have a uncontrolled proliferation of abnormal B cells, but these B cells also infiltrate lymph node, and that is why it is called as a small cell lymphoma. No. So what is the basic pathology here? There is an abnormal proliferation of immuno-incompetent B cells. Now this word is very important. So B cells is here there is a proliferation of B cells, but they are immuno-incompetent. Okay, and they generally start proliferating in the peripheral blood as well as in the mantle cell of the lymph node. So these are the important one-liners which you have to remember about chronic lymphocytic leukemia. Let's look at what are the causes. So there are some chromosomal abnormalities which are associated with CLL. So let's look at the most common chromosomal abnormalities. So there are some very important deletions you have to remember. Deletion of 11q, 13q and 17p. Okay, so these are all 11, 13, 17. These are the deletions. There is a trisomy of 12, again related with your CLL. Now remember, a very frequently asked question is what is the most common chromosomal abnormality? Okay, so the correct answer will be 13q. Again, this has been asked as an MCQ. These are all one-liners which have been asked in various exams. So these are the most important chromosomal abnormalities: your deletion of 11q, deletion of 13q, deletion of 17p, and trisomy 12. So these are the important, but the most important is obviously the deletion of 13q. Okay, for chronic lymphocytic leukemia. There are some couple of other chromosomal mutations which you have to remember. For example, there is a gain of function of Notch gene. Okay, so Notch gene, in your pathology you will learn more about it, but there is a gain of function of Notch gene. There is also overexpression of two specific genes. One is BCL2, that is your anti-apoptotic gene. So once it is overexpressed, so apoptosis will be inhibited, and another is ZAP70. So both these are very important points. ZAP in fact has been asked. ZAP is nothing but zeta associated protein. So all these are important abnormalities, chromosomal abnormalities, which is found in your chronic lymphocytic leukemia. There's also somatic hypermutation, which is seen in these B cells. Now, wherever somatic hypermutation is seen, remember, they are basically your slow growing tumors. Very important. So, needless to say that wherever somatic hypermutation will be seen, they will have good prognosis. They will have good prognosis. Okay. In fact, there are only two chromosomal abnormalities which are associated with good prognosis. Let me just mark them for you. So one is your somatic hypermutation, and second is your the most common mutation 13q. So these two are associated with good prognosis. Rest, all the other mutations are generally associated with poorer prognosis. Okay, now there is another very important point which even in viva, in your professional examinations, or even it has been asked as an MCQ, is this chronic lymphocytic leukemia is not associated with radiation exposure. Normally, hematological malignancies have a close association with your radiation exposure, but this is not associated with your radiation exposure. So, is everybody clear about what are the various, chromosomal abnormalities which are associated? Is everybody clear about what are the chromosomal abnormalities which is, uh, associated? So these are the important chromosomal abnormalities which you have to remember. And again, so what are the questions they will ask you? They will ask you about all the chromosomal abnormalities. They have already asked about ZAP70 and BCL2. They have asked about which is the most common, abnormality, and what are the chromosomal abnormalities which are associated with better prognosis. So these are the important causes. Before I move forward in this session, I'll just like to remind you that daily we send updates on WhatsApp about these live sessions, about concept cards, about quizzes, and all. You can get it. All these notifications you can get it if you go to medicoapps.org/groups. So these are various groups: first year group, second year group, third year group, final, intern, post intern. So whatever is relevant to you, just join that group so that you will get notifications or updates in the group based on that. Now remember, these groups are only admin post only, which means I will only be posting. So there will not be any side talk, no good morning, good evening, good afternoon messages, no forwarded jokes. Only high quality updates will be there in these groups. So I would really request you, we have formed some limited groups and I hope you become a part of it. So having understood what are the various chromosomal abnormalities, let's quickly look at how the pathogenesis pans out in this case. Now we know there is a abnormal B cell proliferation. Now these B cells are not normal; they are incompetent B cells. Okay, immuno-incompetent B cells. So obviously there will be increase in the B cell. There will be some major findings in the bone marrow. There is a cytoskeleton, vimentin, which is defective. Vimentin, we know it's a cytoskeleton. So again, this has been asked, and there are some manifestations because of that. And there is immunoglobulin. We know that B cells are important for formation of an immunoglobulin. So abnormal immunoglobulin will be formed. So what happens when B cell is increased? Obviously, you will have lymphocytosis, and these lymphocytes will infiltrate your lymph node and spleen. So even in diagnostic criteria, you will see that there will be increased in the TLC, and specifically if you do a differential lymphocyte count, there will be increase in the lymphocytes, and it will be more than 5,000, for 3 months. We'll talk about the diagnostic criteria, but remember that the B cells are increased in the peripheral smear. There is lymphocytosis, and the B cells also infiltrate the lymph node and spleen, leading to lymphadenopathy and splenomegaly. So these are the first set of manifestations. If you do a bone marrow biopsy, or what are the changes in the bone marrow biopsy? Bone marrow. So obviously bone marrow will be hypercellular, but remember there will be increased in the lymphocyte. Remember here, they will be increased in the lymphocytic precursors, but a consequent decrease in the erythroid and megakaryocytes precursors. Okay, so obviously they will be decreased in the platelet. Okay, and there will be anemia. So again, these two are, so anemia has two different ways which is manifested. One is even at the bone marrow level, there is decrease in the erythroid precursors and there is decrease in the platelet precursors. So that is very important to remember. As I've told you, this cytoskeletal molecule vimentin is effective, so this will lead to fragile lymphocytes. So not only these lymphocytes are immunocompetent, non-immunocompetent, but they are also fragile. So again, when we look at the clinical manifestation, they will generally, when you make a peripheral smear, they will present as smudge cells. Okay, smudge cells, they will present as smudge cells. And what will this abnormal immunoglobulin lead to? So obviously there will be hypogammaglobulinemia. Okay, and this abnormal immunoglobulin can even induce autoimmune hemolytic anemia or autoimmune thrombocytopenia. Okay, obviously these immunoglobulins are abnormal, so there will be increased rate of infection. In fact, this is a very favorite question. This is the most common cause of death, in your CLL patients. So this is how various pathogenesis will happen. Let's quickly look at the clinical features, how a patient of CLL will present with you. So remember, this is the most common hematological malignancy in your adults. So the age of presentation is more than 65 years. Okay, more than 65 years. In fact, if you see the mean age of presentation, it is mentioned at around 72 years. So these are relatively older patients, and as I have told you, these are growing tumors. They are not fast growing tumors, they are slow growing tumors. And so you will have a lot of non-specific symptoms when the patient present to you, and these non-specific symptoms will be primarily due to hypermetabolism. Okay, what are these non-specific symptoms? So the patient may complain of night sweats, weight loss, even low grade fever, or primarily of fatigue. This fatigue may be because of anemia. Okay, we have seen that autoimmune hemolytic anemia can be seen, or even there is a decreased formation of blood because of erythroid precursors is decreased in the bone marrow. So the patient will present with very non-specific symptoms like weight loss will be there, even significant weight loss can be there, night sweats, low grade fever, fatigue. You can also get a history of recurrent pneumonia or recurrent infections. Even herpes zoster or herpes labialis can be activated. So that history you can have. And if you examine the patient, you will have pallor, you can have petechia. Generally the patient does not complain of lymph node, but once you examine it, you will see multiple lymph nodes being enlarged and spleen being enlarged. If the platelet, because of the autoimmune thrombocytopenia, is decreased very low, then you can even have epistaxis as the presenting feature. But this is relatively rare. The most common presenting feature is basically non-specific symptoms like night sweat, weight loss, low grade fever, fatigue. And generally, when they are worked up, when you do a peripheral smear, it is then when you see that there is a huge increase in the uh, uh, lymphocytes, and then you start thinking in these terms. So this is here. This is a patient, you can see the petechiae developing over his back. So this is how the clinically the patient will present. How do you work up? So the first is basically you will do a TLC done. You know that normal TLC is 4 to 11. So here the TLC will be raised, but here you have to specifically demonstrate the B cell lymphocytosis, and the cutoff is 5,000 per microliter demonstrated for more than 3 months. So both the value as well as duration is important. Remember the earlier cutoff was 4,000. Okay, 4,000, but now it has been changed. All the latest book have started mentioning 5,000 per microliter for 3 months. So this will give you when you do a peripheral smear of this patient. Okay, so this is a peripheral smear. I told you because of the cytoskeletal weakening, when you do a smear, the cells are fragile and they will break. So you can see this is such kind of smudge cells. They are called as smudge cells or basket cells or even parachute cells. So all these are different name of the same cell. And along with the history, if they give you a peripheral smear, you should be able to give. Also, because all these WBCs, B cells are abnormal, so they start looking very similar to each other. You know? And so these WBCs, which look very similar to each other, this gives us something called as convent girl appearance. Convent girls, they look very similar. They are clubbed together. So that is what these B cells, this typical appearance is talked about. That is called as convent girl appearance, because these B cells, these abnormal B cells, morphologically look very similar to each other and they are in clusters. So that is why the appearance is called as convent girl appearance. Is it clear, all of you? So again, to establish a diagnosis, you will do investigation of choice is flow cytometry. Now, flow cytometry is the investigation of choice. A very common question in Viva they will ask you is that what sample do we take for flow cytometry? Is it bone marrow biopsy? Is it peripheral blood? So remember, flow cytometry is done on peripheral blood. Remember this very important point. Okay, this is asked as a viva in your path. So flow cytometry, which is the investigation of choice for diagnosis, is you know done on peripheral, not smear, peripheral blood, and you will get various tumor markers being shed as present. So CD19 we all know is a B cell marker. Okay, then we will have dim CD20, CD21 and CD23, and here we will have CD5. Now CD5 is a T cell marker. So here we have a B cell with a T cell marker. Okay. So here we are having a B cell with a T cell marker. So this is how a flow cytometry of uh, chronic lymphocytic leukemia will. Yeah. Now, very important that there is another similar presenting lymphoma, and in that case when you do it, what you will have is all these, but CD23 will be missing. Okay, similar flow cytometry finding, but only thing is CD23 will be missing, and that case will be mantle cell lymphoma. I'll talk about how to approach and analyze the CD, markers, but just remember it. So that is why investigation of choice is flow cytometry. So all these will be marked positive. Okay. Generally, we do not do a lymph node biopsy, but lymph node biopsy is indicated only when the size of the lymph node is increasing, very fast. There is a fast progressive increase in lymph node along with pain or fever or these symptoms. Now, this basically indicates that this slow growing tumor has converted into a high grade, tumor. Okay, and this is called as Richter's syndrome. Okay, and that we can learn basically by various acquiring additional mutation, they will convert from chronic lymphocytic leukemia to diffuse large B cell lymphoma. So Richter's syndrome, then only we do a lymph node biopsy. But for educational purpose, if you do a lymph node biopsy, first you will see is diffuse effacement, which means you can see that throughout the lymph node there is a B cell infiltration, and then you can see certain areas where there is focal proliferation, and these areas are called as pseudofollicles. So these are the two important findings. So first is the B cell is infiltrating the entire lymph node, so this is called as diffuse effacement, and there are focal areas where there will be proliferation, and this is called as pseudofollicle. So these are two important points. So remember, lymph node biopsy is only indicated when you suspect that in the chronic lymphocytic leukemia is converted into diffuse large cell B cell lymphoma, okay, which is a high grade transformation. So these are here. As I've told you, let's quickly see how to approach CD markers. If you see a CD19, so you know it's a B cell, okay, marker. Then quickly you will see for a CD5. Okay, if CD5 is there, you look for CD23. If CD23 is present, I told you it will be chronic lymphocytic leukemia. If CD23 is negative, it will be mantle cell lymphoma. Is it clear? So CD19 will be present in all B cell tumors. If you have CD5 and CD23, you are looking at you know uh, chronic lymphocytic leukemia. Okay, and if you have CD23 which is missing and FMC which is being present, or CD22 which is being present, then you have mantle cell lymphoma. But CD23 itself will help you diagnose between CLL and mantle cell lymphoma. Again, if it is CD5 negative, then you look at CD10, and if CD10 is positive, you have follicular lymphoma. Okay, if CD10 is absent, then you look at CD25. If CD25 is present, you have hairy cell lymphoma, and if CD25 is negative, you have marginal zone lymphoma. So these are the various B cell tumors, and how you can differentiate based on CD markers. It's a very simple algorithm, very simple diagram. Again, I'll explain it to you. So first is you will look at CD19. So CD19s tell you that you are looking at a B cell, malignancy. Then you will look at CD5. If CD5 is present, then there is only two possibilities, either CLL or mantle cell lymphoma. You quickly look at CD23. If CD23 is present, it is CLL. If CD23 is negative, it is mantle cell lymphoma. Yes, others also you can remember, but it is primarily with the help of CD23 you will be able to diagnose. If CD5 is negative, then you will look at CD10. If CD10 is positive, it is follicular lymphoma. If CD5 is negative and CD10 is also negative, then you quickly look at CD25. If CD25 is present, it is hairy cell. If CD25 is negative, it is marginal zone lymphoma. So this is how you approach, how to approach with CD markers when you are given a flow cytometry finding, because a lot of clinically integrated questions are asked these days. Let's talk about staging. There are two important stagings which are important for CLL. One is Sawatsky staging, also called as Rye-Sawatsky staging, and second is Binet classification. So both are very simple basically. Okay, so let's talk about Rye-Sawatsky staging. So here what happens, okay, in this staging basically we classify patient in low, intermediate and high. Low is when there is a only lymphocytosis present. Okay, intermediate is when there is lymphocytosis as well as lymph node enlargement, and the high risk is when there is lymphocytosis, lymph node enlargement, and you have the autoimmune hemolytic anemia or autoimmune thrombocytopenia. Very simple. Only B cells, peripheral smear, low risk. B cells in peripheral smear plus lymph node, intermediate. All the three, B cells, lymph node, as well as autoimmune hemolytic anemia or thrombocytopenia, it's high risk. Now this is the most common presentation, very frequently asked in the So 25%, one-fourth of the patient will present you in low risk, one-fourth of the patient will present in high risk, and almost 50% will present in your intermediate risk. Let's look at the next classification. This is called as Binet classification. Now, Binet classification is again, it's basically talking about lymphadenopathy. Okay, so if it is less than 3 areas of lymphadenopathy, it is called as class A. More than 3 areas of lymphadenopathy, class, yeah, more than three with autoimmune hemolytic anemia or platelets being you know decreased. So autoimmune hemolytic anemia or autoimmune hemolytic sorry, thrombocytopenia, both, it is basically either it is class C. So again, both these classifications are very very easy to understand. Let's quickly look at how do we manage the patient. Now, at the start only I told you these patients are relatively old patients, 72, so they may not tolerate, and anyways this tumor is a very very slow growing tumor, so they may not tolerate your chemotherapy. So if it is low risk patient, okay, and if they are older patients, stage patients, then you will primarily go for conservative management. If it is a high risk patient, if it is a high grade tumor, then you will use two protocols, either FCR or PCR. FCR is fludarabine, cyclophosphamide, and rituximab, and PCR is pentostatin, cyclophosphamide, and rituximab. Now remember, rituximab, a very important, we will learn more about that in your pharma classes. Basically, it is a CD20, anti-CD20. Remember this. And there is a CD20 expression here. So anti-CD20 rituximab is used. So FCR and PCR, these are the two protocols. They have asked you about drug of choice, for the treatment. So drug of choice is fludarabine. Remember, this is the drug of choice. They've also asked you about treatment of choice. So treatment, if you want, it has to be allogenic bone marrow transplantation. There's a latest drug on which they've asked a question, I think last year or last to last year, that is aldutinib. So aldutinib is a latest drug which can be used for CLL patient, and basically it works by B cell tyrosine kinase inhibitor. So all these have a tyrosine kinase pathway being activated, leading to a tumor formation. So this is a inhibitor, tyrosine kinase inhibitor, B cell tyrosine kinase inhibitor. So this is a new drug, aldutinib. So this is the entire thing about treatment. uh, so any questions till now? Anyone? Any questions till now? Okay. So once we have learned, so this brings us to the end. This was a short topic and I have covered it in very, very precise way. And if you really like this session, I would like you to give it a thumbs up. And if you want, if you have any questions, or if you want to, suggest some other, high yield topic which I should take, leave it in the comment. Make sure you share it. It will reach to much higher audience. And if you are new to our channel, subscribe it. With that, I'll close my session. Again, a small reminder about our Medicoapps group. You can go to Medicoapps/groups and you will find group relevant to you, and these are very high quality updates which we send. There's absolutely no forwarded messages. There is absolutely no good morning, good afternoon messages, only high class update. And because I want you to experience, right? So this completes. Any question, any comment, if you will just put it in the comment, I'll be able to answer any question which you might have, anything which you did not understand in the session. So it's a pretty straightforward. Let me talk about what are the questions which you can expect in this question. So first is, they can give you a clinical case in the exam, and clinical case will be about non-specific symptoms in a patient who is like a adult more than 60-65 years. And then they can talk about, when you examine, he's having anemia, he's having thrombocytopenia, and he's having lymph node. So that kind of clinical questions they will give you. They can give you even one liners based on what are the abnormalities or mutations. So all the mutations you have to remember. Okay, which mutation leads to good prognosis, which mutation leads to bad prognosis. So that questions they are going to definitely ask you. They are going to give you a PS, peripheral smear, especially smudge cells, when you do a PS. And they can talk about flow cytometry. A lot of questions these days are based on CD markers. So I've already given you a small algorithm as to how analyze that CD markers for B cell tumors, and how you can come to a spot diagnosis. You don't have to remember all the markers for all the, yeah. And they have asked about the treatment, especially the latest drug. So this is a short topic, but invariably either as a part of pathology, either as a part of your internal medicine, or so they can ask you. So thank you so much, guys. Thank you so much. And if you can share this about these live sessions, if you can, promote it with your friends. If more students join, it will be more encouraging for me to take these live sessions. Thank you so much. Take care. Thank you, Ravi. Thank you, APLV. Thank you so much for attending this session. Take care. Bye.